In this next video, we're going to talk about the mechanics of ventilation. So how do we actually move air from the environment to our lungs, otherwise known as pulmonary ventilation? This occurs via the process called bulk flow. Bulk flow can be defined as the movement of molecules along a passageway due to a large difference between the pressure between the two ends of the passageway. Right? Inspiration is caused by pressure in the lungs being less than the atmospheric pressure, and the way this is achieved is going to be shown in the next two videos. What you're going to see is the movement of the lungs and the movement of the ribs to increase the size of the lungs in the first video, and in the second video what you're going to see is contraction of the diaphragm. The reason I put these in is the diaphragm contracts unlike really any other skeletal muscle. In fact, it kind of sits like a broad dome shaped, and when it contracts you'll actually see that it lowers becomes lower into the abdomen in order to push the ribs out. And so to actually see that those dynamics occurring, I think, are much more important than me being able to demonstrate it in any type of PowerPoint or hand gestures. So we'll go to that video, come back and talk about more of the basics.
The movement of the ribs increases the volume of the chest. Result, the air in the lungs is at a lower pressure than the air outside. Air rushes down the pipe, the trachea, from the mouth, filling the lungs. And breathing out, even simpler. The muscles attached to the ribs relax, the weight of the rib cage forces air out of the lungs. So is that all there is to it? Not quite. You may have noticed that you can breathe and your ribs hardly move. How come? Something else must be changing the volume of the chest. Another muscle. This time one you need to see. The diaphragm. As we breathe, it contracts and relaxes.
The primary muscle of respiration is the diaphragm. The diaphragm is a thin, dome-shaped layer of muscle and tendon that separates the abdominal cavity from the chest cavity. It gains its shape from its attachments and from the organs that surround it, especially the heart, lungs, and liver. The diaphragm attaches at the costals along the lower rib cage, high in the front at the sternum, and deeply in the back along the spine. The diaphragm also attaches to itself via a central tendon, making the diaphragm one of the unique muscles of the body. The diaphragm uses its central tendon and its attachments as leverage to flatten during inhalation. The expansion of the ribs comes from the resistance of the internal organs to downward movement. As the internal organs are slow to move, the ribs expand to make room for the lungs. While the diaphragm attaches at the bottom of the ribs, its range of motion never reaches that low in the body. As seen from below, we get a sense of the full range of motion of the diaphragm as it would glide over the aorta, the vena cava, the esophagus, and the internal organs. For more information, visit www.3dyoga.com.
So as we now come back to discuss the movement, notice that ultimately through this bulk flow, again, we're going to, air is going to follow the pressure difference from going to the higher pressure to a lower pressure. So the atmospheric pressure in general isn't going to change. This is usually about 760 millimeters of mercury. And so the way that we then cause inspiration and expiration, since atmospheric isn't changing, is to alter the pleural pressure in the lungs. So during inspiration, as you saw in that video, the diaphragm muscle pushes down, which lifts the ribs outward, which decreases the intrapleural pressure. This intrapleural pressure goes from, again, 754 millimeters of mercury, which is less, which then therefore increases lung volume, and the increase in lung volume will ultimately drive the intrapulmonary pressure down from 760 to 758. With this pressure change now, we have a pressure change from 760 to 758, so air will come in and fill the lungs. It'll fill the lungs then until the pressure inside, due to the air being there, is now equal to atmospheric pressure. During expiration, the diaphragm relaxes the connective tissue that holds these together then allows the ribs to be pulled in and downward, which will ultimately cause a increase in intrapleural pressure from 754 back to our 756 millimeters of mercury, which then causes the lung volume to ultimately go down, which has a resultant in an increase in intrapulmonary pressure. So now you see our intrapulmonary pressure. Intrapulmonary pressure is 763, which is higher than our atmospheric pressure. Therefore, air will leave the lungs, be expelled through expiration. So what do you need to know from this slide? So what you need to know is memorize these values. So memorize atmospheric pressure, memorize the intrapulmonary pressure during inspiration, and the intrapulmonary pressure during expiration. Those are going to be the important values from here. So the muscles of respiration, as that video showed, that the diaphragm is the primary inspiratory muscle. This is going to do almost all of the work of breathing required. It's going to do almost all lifting of the lungs, and at rest it's completely able to handle this. Expiration is passive at rest. So all we do is we have to relax the diaphragm, and the elastic properties bring the lungs, or bring both the ribs and the lungs back to their resting position, which decreases lung volume. So therefore, we don't have to have any extra help there. However, during exercise, we need some help. So first, we have accessory muscles during exercise. The accessory muscles for inspiratory include the external intercostals. It also includes the scalene muscles and the sternocleidomastoid. So these are muscles that are going to ultimately contract to help expand the ribs even more in order to increase bulk flow and increase blood gas exchange to get more oxygen in and more CO2 out. During exercise, expiration can become active, where we actually have the muscles contracting, decreasing that intrapulmonary pressure by squeezing the thoracic cavity. This occurs during exercise or during hyperventilation, of when we force increased expiration out. And the muscles involved in that are the internal intercostals. The abs also help in expiration, and rectus abdominis. So the obliques and the abdominal muscles are both going to help, again, squeeze that. And if you think about it, if you try to breathe out, you can actually feel your abs working and pulling that. So that tells us how we get in, decrease the pressure, but that's not the only variable. So the last variable that we'll talk about in this section is airway resistance. So airflow, just like our blood pressure, is due to the pressure differences between two ends of the airways. So again, external environment versus intrapulmonary pressure, and the resistance or the size of the airways, right? So this is a size in diameter. So we can see here, a low resistance would be, for example, a vessel that is very large, so a large trachea. Or if we decrease the size, then we have a very high resistance. So again, airway resistance is going to depend on diameter of the conductance zone, primarily of the bronchi leading into the lungs. Certain diseases can reduce this. The two most common are asthma and COPD, and we'll highlight asthma here, and as you can see. So here's the normal bronchiole. There is some type of inflammation which causes a spasm, or as you can see, this bronchiole has layers of smooth muscle circulating them. So here's smooth muscle. So when we get contraction of those smooth muscles, we actually get a narrowing of the diameter of the bronchiole in an asthmatic patient, and ultimately that can cause an increase in fluid and mucus filling the airways. Right? So the treatment for this is to add some type of bronchodilators, which would then cause the bronchial smooth muscle to relax and open the airway back up, if you ever wondered what kind of drugs you're taking. And so that's how we approach that. So to summarize this section, the diaphragm is the primary major muscle of inspiration. It allows us to bring air from the external environment due to the intrapulmonary pressure being reduced by a contraction of the diaphragm below that atmospheric pressure. Blood airflow then moves from the external environment to the internal environment. At rest, we expire passively by just relaxing our diaphragm and allowing the thoracic cavity to compress on its own. However, we can have active during exercise or hyperventilation, where we use muscles in the abs as well as the internal intercostal muscles in the ribs to help assist in that. And then ultimately, for the most part, the primary factor that contributes to airflow resistance is the diameter of the bronchioles. For most people, this doesn't cause a problem, but in certain diseases, it can be problematic, as with asthma, as we talked about.